lots of education with the stretching, and then monitoring for if we're losing range of motion. This is where we might get our orthotist involved. Often we'll use splints or braces to help with stretch. You know, if someone's hand's getting tight overnight and they're waking up with, you know, their hand clawed and tight, we might put them in a splint to keep them stretched, a nice prolonged stretch overnight so they don't have that. You know, in the morning, we will also use, you know, ankle foot orthoses down, you know, if we're getting a lot of spasticity in the foot and ankle to maintain that range. We could put them in a splint at night to keep a prolonged stretch there. So lots of interventions that I would say are on the easier side of things. You know, there's no side effects from, you know, stretching and monitoring and bracing. You know, then sometimes that's still not enough and we need to get more aggressive in our management. And those are times where, you know, we might, if they were not in therapy, we might need to restart therapy to really work on the spasticity more. We can use oral medications. There's a lot of different agents that we can use, but the drawbacks of that are that they can cause drowsiness, and then they can cause some weakness in other muscles that don't have spasticity that are working really hard to recover. So it's always, you know, it's weighing our risk and our benefits for, you know, the management on that regards. Then we also have our botulinum toxins, which are injections into the muscle. But the nice part about that option of treatment is we can target specific muscles. So if we have a certain muscle that's, you know, has more spasticity than others, we might not want to do an oral medication and relax everything, but we could target the problematic areas. So that's a good option as well. And then there's even more aggressive managements like intrathecal baclofen pumps and, you know, having surgery and releasing muscles. But, you know, we really hope that we can, you know, work on the less conservative, you know, I mean, the more conservative side and less invasive, you know, to get those treatments before we have to get into bigger surgical procedures. But spasticity is also, it's a very unique thing. I think it definitely falls into the art of medicine because it's not all spasticity is bad. So, you know, if I have a person who has a flaccid limb, so, you know, they can't stand, they have no movement in their limb, and then they start to develop spasticity, let's say in their quadricep muscle. So that's causing them to keep their knee extended. Well, that gives us a leg to stand on. So, you know, I have people that are functioning based on their spasticity. You know, without that spasticity, they might not be able to stand and walk, but we use that spasticity. So those are in those situations where we really have to dig into what is our spastic area, and it doesn't necessarily mean we get rid of it because often we're functioning, you know, using that spasticity. So we have to really dig into, again, what are the goals of the patient? How are they using the spasticity? How is it inhibiting our function? You know, and then we have to modify our treatment, you know, in that regard. So it's yeah, it's totally variable in how we you know, treat it.